Hello, everyone, and welcome to another episode of Arthritis at Home. Today, we're joined by Ellen Wang, Programs Coordinator at ACE, as well as a PhD student working out of the University of British Columbia. Ellen, I know you're very busy. Thanks for taking some time off to join us today.
Absolutely, Kelly. Thank you for having me.
Now, in between those roles that I was just describing, you're a very, very busy person. You also have the honor for a second consecutive year to attend this year's EULAR conference representing Team ACE to present an abstract called Health Literacy and Arthritis Care in Canada, the Perspective of BIPOC Men. Congratulations to you and the ACE team for having this accepted, and how exciting for you to be able to do this again this year.
Absolutely, Kelly. What an honor to be representing Team ACE, and truly, what an honor to be speaking about this topic as well. Something that we don't really hear a lot of.
Now, some viewers may have seen an earlier episode or seen a Joint Health Insight where we looked at the findings of our national survey on health literacy in arthritis care in Canada. But they didn't hear us speak about this, subset analysis, looking at the perspective and the lived experience of BIPOC men. Before we dive into that, Ellen, maybe we can just remind people again, what is it that we mean when we refer to health literacy?
Yeah, absolutely. So health literacy, the literacy part, I think most of us understand, right? That is our understanding of information, of usually that is written, or in this instance, right? It can be information also through channels like a video, or channels like media sources, radio, or social media sources, right? Those are all considered sources of information. So it's our understanding of those sources of information and what they're saying. But health literacy now has been expanded to cover not only understanding, but our ability to apply that information in our daily lives to improve or maintain our own health.
Now, what we do when we conduct these, it's a major undertaking, actually, these national surveys, is we have some really smart people led by you and Eric Serre and a few other people who do the actual analysis. And what we do there is we don't just look at the respondents as a whole, but we break it up, as I said, in like a subset analysis. So we look at factors, socio-demographic factors, such as where do these respondents live? What income group do they belong to? What racial group do they belong to? Their education level, and of course, gender. And when we kind of roll that all up and do our analysis, we see, what kind of stands out to us. And with this particular survey, what were some of those key findings that we found when we did that, when we sort of dived deeper and did that subset analysis?
Yeah, absolutely. So we, published on the website, on the ACE website, the results for BIPOC individuals. And we found that there were discrepancies in certain, you can say, aspects of health literacy. So for example, we found that BIPOC individuals, even though they understood health information, they actually had quite a bit of trouble, or I should say they faced more challenges when communicating with their healthcare providers. So it wasn't a lack of understanding, it was a lack of difficulty in those interactions with healthcare providers. But we then went a step further to look not only at BIPOC respondents as a group, but we looked at BIPOC men specifically. And I, acknowledge that I myself am not a part of that group that we're talking about, but we looked at specifically BIPOC men. And again, what the data showed us was that there are specific challenges that are experienced in terms of health literacy for this group.
just for our audience, if they're not sure about what we mean by BIPOC, it's Black, people of color, and Indigenous. And that's the acronym that is sort of commonly used to describe those patient populations.
Thank you, Kelly.
What sort of representation did we have in the survey from the BIPOC community?
We actually had quite a high level of representation. We had about 449 respondents out of the total, which was 1,140.
Oh, wow.
So you could say like it was a very good percentage. It was just under about 40%, but really that's, you know, for a national survey, we actually did a very good job of capturing, of reaching those individuals.
And when we looked at BIPOC men, I think you started describing to us some of those characteristics that we found in the responses. Did we find some areas where they were particularly challenged?
Yeah. So our data showed that, again, BIPOC men, which was 236 respondents out of the entire BIPOC subset, which was 449, these individuals actually displayed higher levels of understanding when compared to white men. So very high levels of understanding, very high levels of education, very high levels of annual income. So you could say that they're, you know, higher, I'm going to use that word, higher socioeconomic status.
Which would almost be a limitation in terms of the research.
It is a limitation. We'll touch on that after. But the really, the part that we didn't expect was that despite seeing, you know, higher levels of understanding, of education, of annual income, these individuals still faced greater and truly disproportionate challenges when they took that information and tried to apply it in their daily lives, right? So understanding was good, but the taking of the information, applying in their daily lives, we saw differences when we looked at exactly, specifically medication instruction. So, and understanding how to take medications, when to take them, and the timing of taking medications, as well as exercise. So understanding the purpose of exercise and knowing how to participate in exercise. And then we also saw it for nutrition. So understanding the purpose of nutrition, even though they understood health information, but when you look specifically at taking that health information and applying it to medication, to exercise, and to nutrition, we saw challenges there.
So can we draw a connection that if they're receiving this information from a healthcare provider, that there's some challenges at that level in terms of the interaction with their healthcare provider?
If we actually look at the data, the interactions with healthcare providers, that section is a part of our survey, actually showed very comparable results. That said, even though you're in an interaction with someone, a healthcare provider, and you're understanding that information, it can be communicated to you quite well, you think you understand, but then you get home, and when you're left to your own devices, there seems to be challenges. So I actually don't know exactly where that challenge starts or what part of that challenge is it that's, you know, perhaps these individuals are really busy. They just don't have the time to sit down and take the knowledge and apply it. Or are there, you know, cultural barriers? They understand the information, but for cultural reasons, there's a barrier. Or perhaps there's some other reason, whether that's structural as a part of our healthcare system. We didn't capture that specific information, but it is a really good line of questioning for further research.
And I guess it's part of the experience that you're going to have going to EULAR, being able to present this poster and be able to have these kind of conversations with some really smart people who will probably lead you into maybe some of these areas of questioning, but it might even spark or motivate their own line of thinking and their own line of research too. So that must be exciting to be part of that exchange coming up for you in a couple of weeks. So in terms of the findings that you've described, what were the conclusions that you included in the abstract?
So as you had alluded to, we noticed, or we concluded, that this is really only a starting point. That we need to continue to build the understanding in differences across groups of people, and that we each have a role to play. So for example, researchers, even though this concept of patient engagement or patient involvement in research is now very mainstream, very much so supported by health governing bodies, specifically, we need to do more to reach the groups that are not already at the table and include their voices in those research studies as members of the research team. But on the other hand, healthcare providers, in their own interactions with patients who may experience unique cultural barriers or structural barriers, they have to maybe take a moment and ask themselves, do I have certain biases about this individual? Is there something I'm bringing into the interaction that is actually not helpful in that interaction? And advocacy groups like ourselves, we need to do more to provide educational resources that emphasize skill development. So thinking to ourselves, a lot of the stuff that ACE produces, even though it's really well written, it's it's accessible, have we really thought about ways where we can write it to help people take steps, small steps towards actually taking medications on time, the right dose, how to participate in exercise, purpose of nutrition, like how do we translate the education that comes on a piece of paper or digitally to action? So thinking about that really hard for advocacy groups. So we all have a role to play, and this is really only just the beginning.
Thank you, Ellen. And congratulations again on the abstract. And we look forward to hearing about your experience while you're at EULAR. And of course, when you come back. So good luck. And once again, thank you for joining us today.
Thank you to everyone for offering their time and their experiences for completing this survey. Just remember that we get to do the work that we do because you have shared your time and shared your energy in completing these surveys. So I do want to thank the audience, thank anyone who participated.
And I'll just add to that by thanking all of you for joining us today on another episode of Arthritis at Home. We look forward to seeing you again soon. Bye-bye.